Hello, everyone. Jay here. Sadly, with COVID and everything, I can't give my in-service in person, so I thought I would come to you in this format. So hopefully this all works out. Hopefully you can see me down in that little corner, because I think that's a little bit more fun, but who knows? Not the best with technology. But so in the first few weeks of being on the cardiac ICU, had a few patients that had a diagnosis in their chart, and it said peripartum cardiomyopathy. And this is something I had really not heard of. I'd never heard the terminology, and very odd to have multiple patients kind of at the same time come up with it. But they had all had it at really different time frames. Some had had it 12 years ago, and a few had it just 3-4 weeks ago. So really kind of a broad spectrum. So I decided to do some digging to find out and just kind of present to you all what I found. So we'll get right into it. But first of all, just a little background. Personally, I've never given birth. So I did not know how much the heart in general just goes through during pregnancy, even during a normal pregnancy. But so basis of it, hormones are secreted by the corpus luteum, and they lead to a whole bunch of cardiovascular changes. And that's a very simplified version. But one of the biggest things related to this cardiomyopathy is that the increased blood demand, both from the fetus, from the uterus, induce hypervolemia. So the body's holding on to quite a bit more fluid, mostly just because of that blood supply. And how body kind of deals with this is increases cardiac output by 30 to 50%. Peripheral vascular resistance quickly decreases in order to get blood everywhere else. So around week 5 of pregnancy, so pretty early, blood pressure begins decreasing pretty substantially. I don't have specific numbers, but lower than usual. The left ventricle is specifically accommodate by increasing end systolic and end diastolic dimensions. So they stretch, the heart kind of stretches more is the understanding that I have of it. And then left ventricular mass is increased in all normal pregnancy. Sorry, I'm just gonna move me a little bit. So that muscle just gets stronger, it gets stretched, gets a little bit, has to work harder essentially, because it's doing a lot of work. And so understandably, it gets a little bit bigger. However, these changes spontaneously kind of go back away. So normally these will all resolve by 3 months after pregnancy, or at least that's kind of how research currently understands it. But then what happens in peripartum cardiomyopathy? So what is different about these patients or whoever develops this? So at its core, peripartum cardiomyopathy is left ventricular dysfunction and development of heart failure. So it's very, very similar just to kind of congestive heart failure as we would think of it. About half of patients will also have right ventricular dysfunction, so they'll get both sides involved. The big thing about this though is that there's no other cause. So they do a bunch of screening that I'll talk about here in a little bit, but there can be no other underlying cause of the cardiomyopathy for it to be diagnosed as peripartum cardiomyopathy. It can only occur within the last month of pregnancy or up to 5 months postpartum. So a pretty tight time frame in that 6 months. There's not a great understanding of it currently, but the two kind of main hypotheses, there's this idea that there's an underlying cardiomyocyte protein mutation, and I don't necessarily know if they found genes specifically responsible for this, but there's this mutation that when you throw in all those demands that the heart has during pregnancy, that mutation leads to these cells to spontaneously go through apoptosis and die, essentially. So the cells die, and that leads to heart failure because the heart just isn't strong enough to kind of keep up with those demands. The other theory is that one of the other hormones, prolactin, when it breaks down, these products produce vasculotoxic effects that then cause this heart damage. With that one, personally, I just don't quite wrap my head around it quite as well, but because my big question with this is, why do some women develop this and some not? Because everyone's going to have that prolactin breakdown, but not everyone's going to develop this cardiomyopathy. So that's just one question. I am not totally sure about it. So some other things that can increase risk of peripartum cardiomyopathy. There's increased incidence with increased maternal age. Black women have higher rates of peripartum cardiomyopathy and pregnancy-associated hypertension. Um, One example is preeclampsia, but really any form of hypertension um, during pregnancy can increase the risk. And then multifetal pregnancies will also have higher risk. Again, hypothesis on my part, but I assume if you have two babies growing in your belly that you're going to have even higher blood demands, even higher cardiac output and everything. So I can only imagine that's just, yes, even more work on the heart's part. So how will they diagnose peripartum cardiomyopathy? So the first things that someone will typically realize: shortness of breath, dyspnea, worsening peripheral edema, ankle swelling, feet swelling, or chest pain or discomfort. Now, my big thing when I read these and was starting to look into it is that those all sound like things that would, besides chest pain maybe, but all things that would reasonably happen in any quote unquote normal pregnancy. Um, I pretty much hear that everyone gets swollen ankles, always harder to breathe. So it's relatively similar. I think the chest pain is kind of where things start to differentiate themselves a little bit. But testing wise, they'll go in, they'll do an EKG. The specific kind of two things that they have to find to be able to diagnose this is a left ventricular ejection fraction of less than 45%. So that's just the number that they have, and increased left ventricular end diastolic dimensions. Not a specific number on that one that I could find, or there maybe was, but it was kind of beyond me and beyond our purposes of needing to ever diagnose. But they'll also do CBCs, they'll do urinalysis, chest x-ray, essentially trying to rule out any other cause, because like I said, they essentially can't be anything else that's causing this heart failure. It can't be renal failure, kidney stuff, so that's causing it. Otherwise, they'll kind of go on to different routes. Maybe it's heart failure from a different cause, but it's just not specifically peripartum cardiomyopathy. Disease management. So what will they do to manage these patients? Fluid airway management is kind of the big thing that they'll do this whole patient's hospital stay. So they'll treat with antihypertensives if needed. Not everyone that has this is going to be hypertensive. They'll do ACE inhibitors to manage fluids, anticoagulants to make sure that they're not clotting, because that is one of the big complications. And then prolactin inhibition. So this is one of those theories, is that the prolactin breakdown is in causing heart damage. So they will medicate to inhibit the breakdown or inhibit even production of prolactin. And then depending on whether or not this patient has had their baby yet or has not had their baby yet, they'll manage two different ways. If they've not had their baby, anesthesia will be on board, kind of making sure that everything during the pregnancy is really well managed and everything during delivery. And then they prefer to do a vaginal delivery just because since there's heart damage involved, not necessarily wanting to go through a C-section, dealing with even more anesthesia and more risk involved in that. Postpartum, so if they find these symptoms and find out that they have peripartum cardiomyopathy after they have their baby, they will manage with contraception, essentially kind of making sure that if this patient is going to have another pregnancy, it has to be really well thought out. Modest exercise can start at any point. They won't necessarily wait any longer, but how we would treat a heart failure patient is kind of how we would treat these patients as well. So increasing heart demand just slightly, kind of to work on, obviously within limits of asymptomatic tolerance, but trying to increase heart function. And then they'll do an EKG in 6 months after the patient has given birth, and then they'll do one every year thereafter. I've seen typically kind of every year for the rest of this patient's life, to really manage and make sure that there's no longer effects. So what does the disease process kind of look like? So the really interesting thing, I think, is that here in the US, about 65% of women just spontaneously kind of get better. So they regain ventricular function, specifically with that measure of ejection fraction going up above 45%. So a good chunk will just kind of get better over time. And that's within 6 months after pregnancy is 65% will get better. Rate goes up even farther that we get out. But then complications, things that happen to some of the others that don't just kind of spontaneously get better that quickly. So clotting is the biggest issue. Around 7% of patients will have issues with clotting. Arrhythmias, super commonly, or not super commonly, because that's less common a little bit than clotting, but commonly develop after this. If a patient is having even worse ventricular dysfunction, they'll do things like intra-aortic balloon pumps. There's ventricular assistive devices, whether that's an LVAD or whether it's an Impella, they might use that just to get those ventricles functioning better. May have to go on ECMO in the worst cases. And the patients with pretty high levels of dysfunction will pretty much immediately get worked up for transplant. An interesting fact I found is that 5% of cardiac transplants for women in the US are due to peripartum cardiomyopathy. So a pretty good chunk. The mortality rate from this is about 3 to 4% in the US, higher in more developing countries. And the most common cause of this is just from sudden cardiac arrest. And then here's the other cool thing that I just think is really interesting, that in subsequent pregnancies, so again, they'll make sure that everything is really kind of well thought out for following pregnancies. But for those that regain their left ventricular function in that first 6-month period right after pregnancy, so pretty quickly, only about 21% of those women will have a recurrence of this peripartum cardiomyopathy. So some of them will just have another pregnancy, no issues. And again, some of that may just be because they're managing blood pressure better, they're doing other things, kind of looking out for things, but not a huge percentage. However, those that don't regain left ventricular function in those first 6 months will have a little bit higher rate. 44% of them will have this recurring peripartum cardiomyopathy. So just a little interesting that things can be different the second time around. And it's not always the first pregnancy that this happens, which we'll talk about in my case. So stay tuned. Okay, but big things that therapy-wise that we really need to know. Not a ton, unfortunately. There's no research yet on specific therapy considerations for peripartum cardiomyopathy. So current best practice is just to follow CHF guidelines. So improving ventricular function with increased activity. So doing the things we do already, walking, getting up, increasing activity tolerance, making sure these patients are functional, doing all the things that they need to do, and then anything, again, that they just need to work on. The other thing though, however, is there will be very strict blood pressure monitoring on these patients pretty much their entire hospital stay, especially if they have not given birth yet. There'll be pretty tight parameters that they'll have. There's not like a set, 10 millimeters of mercury of map that they need to be in necessarily, but for every patient it's going to be a little different, but they'll usually have pretty strict. So just something to look out for, and something maybe to talk with nursing about. Hey, are there certain numbers that I need to look out for? Or we need to be even more careful about dropping numbers or raising numbers while we're doing activity with these patients. All right, so that's, again, wish I had more on that, on kind of what can we do, but we'll get into a case study because I think this is the super interesting part. So one of the cases, again, I mentioned there were a few on the floor kind of right when I started in the ICU, but one of them, this was a 28-year-old female. She was admitted from December 4th to 27th, so about 3 weeks. 3 weeks before her admission is when she had given birth, and it was a vaginal delivery, no complications whatsoever. It was totally fine. This was her third pregnancy, so she had no complications with her first two. Her only other past medical history was scoliosis, and as far as I could tell, it's functional. They never had to do anything to manage it, no surgery or anything. So 3 weeks after giving birth, she had a sudden onset of chest pain. She came in, and on the way to the cath lab, she became unstable and hypoxic. She was immediately intubated. They still went ahead, did the left heart cath, and found spontaneous dissection of left marginal, left anterior descending, and left circumflex arteries. Same day, they placed an Impella, they cannulated on ECMO and did a cabbage ×2. Transplant workup began that same day because I think they just immediately kind of recognized this is worst of the worst. And pretty quickly, very young patient, so wanted to get transplant on board if need be. However, 5 days later, she was extubated. She got a little bit more stable. She was decannulated off ECMO on the 9th, but then had another complication, pleural effusion requiring chest tube placement. Then she was re-intubated on the 13th just for airway management. Things weren't going super well, extubated again on the 15th. So this is 11 days now after her admission. This is when therapy gets involved, specifically on the PT eval on the 16th. She was max assist, supine to sit. Was able to sit edge of bed for 10 minutes. And it was mod assist for sit to stand. She was able to do that 3 times and able to take small steps in place. On the 23rd, the Impella was removed. On the 24th, then, she was transferred from the ICU to progressive care and pretty quickly started to improve from here. So even from the 16th to the 23rd, things started to improve. Right around the 20th is when ambulation kind of started to really take off, and she was able to make it a few hundred feet. But then on her last PT note on the 26th, she was standby assist for all transfers. She was able to make it 300 feet, 350 feet standby assist as well. And then on the 27th, was able to go home. So I think just a really cool kind of progression. Things were really not great for the first about 11 days, and a really pretty quick turnaround right when therapy started to get involved. So cool to see that progression. Kind of can toot our own horns a little bit, maybe that maybe it was therapy kind of getting on board. Obviously, we'll never know. And she wasn't at the point where therapy was kind of appropriate in those first few days, just because they were really concerned with things and concerned with things taking a turn for the worse. But so 10 days after therapy was initiated, she was standby assisted and everything, doing everything she needed to do kind of on her own. She was able to go home on the 27th. The only things that she was being managed for was she was on oral birth control, just to make sure that, especially in these first about 6 to 12 months, it's kind of what I've seen, that they really don't necessarily want to have these patients get pregnant again that quickly right after. Give the ventricles a chance to kind of develop, get stronger before another pregnancy. She was on an anticoagulant and other heart failure medications. And then a patient will frequently come back in to check in with the cardiovascular team. So I think I remember hearing it was 2 or 3 weeks after she left the hospital, she needed to come back, and it was going to be pretty much every month for the first little bit, just to really keep things, because she was on ECMO, like things were not great. So she's going to be managed. Oh, the other thing, she went home with a life vest. So in case of needing to be defibrillated spontaneously at any point, like if she went into cardiac arrest, she had the life vest on that would spontaneously deliver that defibrillation if needed. There's not a ton of research, and not every patient will go home with one of these that has peripartum cardiomyopathy, so I'm not exactly certain what made her a good candidate for this, but maybe they just found something about it that they thought it would work with her. So in case she needed that. So that was her. She did a ton better, was walking, was doing a lot of things. So I'm very, very curious to see how she does, and hopefully there's no further problems and she can take care of those 3 kiddos that she needs to. Some other resources, just in case anyone's interested, in American College of Obstetrics and Gynecology, College of Cardiology has some really good resources listed too. So they both have really good resources listed just under peripartum cardiomyopathy, kind of have some guidelines for it, some recommendations for treatment. And then the American Heart Association also had a lot of good info. So 3 good resources there for anyone that's a little bit more interested. And sadly, again, since we're not in person, I can't necessarily take any questions right now, but if anyone sees me around, has any questions, can't guarantee I'll know answers. I'm not by no means a whiz about this. Again, I had no idea about it 3 weeks ago. So it's been a Really cool to find out about, and just to know about what kind of what the heart goes through during a normal pregnancy as well. I think is very interesting. So, thank you very much. There is like a little quick fact sheet that I'll post on the board in the office in case anyone just wants like little quick notes on this. But thank you so much for watching, and hope you have a great rest of your day.